So good afternoon, everyone, and welcome to our traditional case review. My name is Dorit Shaham. I'm a radiologist from Jerusalem, Israel, and my co-moderator.
Thank you, Dorit. My name is Silva, cardiothoracic radiologist from Italy, Parma. And I'm really excited to be in this session with Dorit, who is the gold standard for this presentation.
Thank you. Okay, so we will ask the panelists to present themselves. Maybe we should go from distal, please.
Jens Vogel-Claussen, radiologist from Hanover, Germany.
Gratama, I'm a thoracic radiologist from the center of Netherlands, Apeldoorn.
I'm Sang-Min Lee, a thoracic radiologist in Seoul, South Korea.
Cham, cardiothoracic radiologist from Seattle, Washington.
Seijo, pulmonologist from Madrid, Spain.
Okay, so many cardiothoracic radiologists. So please scan the QR code. Okay, and we'll start with our first case. This is a testing question. What is your nationality? Okay, so 70% non-Thai and almost 30% going down. Okay. So we start with the first actual case. So this is a 66-year-old smoker with a smoking history of 15 pack years, and he has a questionable solid subpleural nodule in the right apex, as you can see, pointed by the arrow. It's slightly wedge-shaped. It has an average diameter of 8 millimeters, and we thought it could be potential apical scarring. So this is the first CT slice from March 2023. And the first question is, what would you recommend as the next step? And the options are 1 month low-dose CT, 3 months low-dose CT, 12 months low-dose CT, PET CT, or biopsy. Okay, so there is a majority here for 3 months low-dose CT. Okay, and this is actually what we did in real life. So it was 8 by 6 millimeter to begin with, and slightly increased to 11 by 8 millimeters in 3 months' time. So now what would you do? So again, so the options are 3 or 12 months low-dose CT, PET CT, biopsy, or no need for follow-up. Okay, so everyone was thinking it's suspicious. Most people, anyway. Okay. So we did the PET CT, which, as you see here, was positive. And we went on and did the wedge resection, and the pathology was invasive squamous cell carcinoma. Okay, and this is my first question to the panel. How would you differentiate apical fibrosis from suspicious nodules in the lung apex? And Professor Udkirk just spoke about this, right? This is an area where often there is apical scarring. When do you know it's scarring, and when do you suspect that it's lung cancer? So who would like to start?
Shall I start?
Yes, yes, please.
For apical scarring, usually it's symmetrical, relatively symmetrical, and it's in the apical parts of the lungs. We now only have one image, but of course in the scan you can coronally look for more scarring, symmetrical scarring. It could be a little bit asymmetric. And and this one is a little bit atypical location for the scarring, and also the because of its aspect. Usually you can see it coming down from the apex, and it's relatively smoothly bounded. So then you can think of a lymph node, but it does have no characteristics of lymph node period, visceral nodule. So
Right.
would
Also not in
expect
the
more.
correct location, right? Because the lymph nodes are usually the bottom of the lung.
Doesn't work.
Okay. So this was, again, in real time, it was a solitary finding, and this is why we thought it's probably not scarring. And okay, so good job. And we'll go on to the next case. So the next patient is a 78-year-old past smoker, and he is recovered from carcinoma of the prostate. And I show you here two very small lung nodules, around 2 to 3 millimeter nodules. So one is marked A, the other B. And the first question is, this is the high-res sections of the same nodules. And the first question is, which nodules looks more suspicious to you? So A, B, neither, or that both nodules are potentially suspicious and should be followed. Okay, so about half of the participants thought that both nodules should be followed, and the other half is spread, but the majority thought that neither are suspicious. So this is 2 years later. So this patient had biannual screening and not 1 year. And you see that it grew from 2 to 3 millimeters to about 8 millimeters in diameter. And this was, to begin with, it was the smaller nodule, right? The smaller nodule 2 years earlier. Okay, and what would you recommend as the next step? So 3 months, low-dose CT, choline PET CT, FDG PET CT, biopsy or surgery? Okay, so again, 50% think that a biopsy should be obtained, and the next most popular choice was the FDG PET CT, which we did. Again, it was mildly positive or positive. And then we marked it. I don't know how many of the audience or the panel, how many of you use the marking technique for small nodules? No one? Okay, 1, 2, 3. Okay, and this was invasive adenocarcinoma. So very small nodule. They skipped 1 annual screening, and the next year it obviously grew. Still, it was a very early stage diagnosis. So my questions to the panel: what can be done to detect particularly small cancers as early as possible? This is the first question. And then what is the price of delayed diagnosis, and how can we avoid it for these very small lung cancers? So who would like to start? Luis? Yeah.
Well, and this is a major concern, right? It's the watchful waiting is the only option for a small nodule, because if we start biopsying small nodules that we haven't watched, and they're not growing, we're going to biopsy a lot of benign nodules. So I don't think there's much of a choice at this stage, but to watch it. Now, as soon as we develop a biomarker that's robust enough to allow us to make a decision about a small nodule, then we're okay. But at this point, I think we're forced to watch. And there's possibly no downside to watching because it's a way to also discern between fast-growing tumors and slow-growing tumors and whatnot. And we do have a window of time that may be as long as 4 years, right, for a very small adenocarcinoma to intervene. So I think there's little downside in watchful waiting as long as the period that you watch it for is sufficient enough to watch it grow and not too long to watch it change stage.
Okay, any other comments from the panel? Matt?
So I've noticed that at my institution, if the nodules are only 1 millimeter, we don't call it, we just ignore it. And if it's 2, then we'll start describing it or measuring it and reporting it. So 1 millimeter, we figured they're going to come back in a year. We're going to see it again if it's bigger, but we don't even put in a report if it's 1 millimeter.
Yes, please.
Yeah, I mean, in the Hansa study, we go one step further. We don't report any nodules in the report, any nodules, only if they're sent to the positive nodules, which are sent to MDT, we report. Other than that, we just say it's intermediate. There is a nodule, we call them, right? Explain the finding, but in the report, the nodule size is not mentioned. And in the negative cases, nodule sizes are not mentioned as well.
So in this case, you would have not mentioned it at all.
No, I would say if it's intermediate in the first one, right? I'm not sure what the volumes were. That were less than the threshold, I guess, right? But then there's a kicker you didn't mention. You mentioned it's a history of prostate cancer, right?
Right.
This changes the game. This is not your just smoking healthy adult. So in that regard, one say, okay, it has nodules, right? And check the PSA because this could be metastasis as well.
Okay, and if it
Yeah.
was negative?
If it would, we would follow. Yes, we would follow. And it said probably benign. Lung rats too. We use the lung rats and come back in 12 months.
Okay, so just to, I have here Claudia and David's and Roina's paper, which was published last year in Radiology. I think maybe you're going to discuss it tomorrow, or Roina is going to discuss it, but so just a sneak preview. So they retrospectively studied 2 cohorts. One was from the NLST and one from the IASLC. And they saw that, and they checked nodules with size from 4 millimeters to 2 centimeters. And it doesn't matter how small the nodule was, you lose the survival goes down when you wait, even for very small nodules, and this turned out to be true in the 2 cohorts. Okay, so you'll hear more about this tomorrow. Okay, so case number 3, Mario, please.
Thank you, Doris. So this case is about a 61-year-old male, a smoker with 32 back years, and it's indeed a lung cancer screening participant in Parma. Baseline, here's the finding. It's classified subsolid, actually non-solid nodule in the right lower lobe. So by protocol, we see it again 1 year later. And you see the morphology. So we have the detail here. So the question about radiologists reporting and clinicians managing this kind of nodule, how would you interpret this evolution in 1 year? Would you call it stable, increased in size, or we describe a bit more increased in size and density? Or even more detailed, we say this is increased in size, increased in density, and there is some morphology that might be targeted for the discussion. So we see most of descriptors are saying this is increased in size and density, and somebody a bit more detailed in the report probably also saying that there is a kind of concave margin in the anterior aspect of the nodule. So, sorry. So 2/3 of the voting presents are saying this is increased in size and density, but up to 1/3 said that there is also some morphology to be looking at for this nodule, which would be this concave sign in the anterior aspect. So given that interpretation, what would be your next step? So what do you recommend as a management for this nodule? Direct surgery? Was that a surgeon responding?
Yeah.
So somebody's suggesting another 3-month low-dose CT, but please remember we had a baseline non-solid nodule, persistent at 1 year with signs of progression. So probably we might need reassurance that the growth is indeed confirmed. But probably that's already something that we might want to manage somewhat else. Okay, so quite even answers. And we go from the most conservative one, which is another CT in 3 months, to the most invasive one, which is already surgery. Sorry. So we went to surgery for this case, directly to surgery, and this showed up to be an adenocarcinoma. Of course, we know that persistent subsolid nodules most of the times represent adenocarcinoma, but we have to have a clinical interpretation of what we see. So some of them might not be clinically relevant in the face of comorbidities that we might have for those subjects. And the morphological interpretation just beyond the size, going to the density change, but also morphology might somehow help. And the concave sign is associated with higher risk of infiltration, if you want. So at this point, I'd like to ask also to our panelists, what would have been their management for this nodule? And we go with a pattern proximal to distal, if you want.
Well, to me, the behavior just asks for either biopsy or resection. So I find PET CT scan in these smaller adenocarcinomas is not very helpful and can be misleading. So you get a lot of false negatives and maybe some false sense of security that you can wait and continue to follow a nodule like this when it's already behaved in a malignant fashion.
Yeah, I agree. The PET CT for this case would have been low likelihood of positivity because we know. And the aim of staging, again, actually the likelihood of having a positive lymph node is extremely low. We know from publication from Mount Sinai back five years ago already what is the likelihood of having those nodules with mediastinal lymph node positives.
And you get distracting results. So it's not uncommon to get a PET scan in this situation and you see something in the colon that you have to do a colonoscopy for, and this is before the resection, so it delays definitive treatment of the cancer.
So you agree with surgery, basically?
Yeah.
What about
Yeah, I think if you have a follow-up, as in this case, you have a clear growth or increase in density, there is no role for PET CT because the growth trumps the mild, uptake. If there's no uptake or mild uptake, it's concerned because there's growth. So I think PET CT has a role, but mainly in baseline, right?
Yeah.
Where you decide maybe you don't want to wait 3 months, only in a very, very few cases, there it plays a role, and the predictive value of the nodule is substantial for cancer. I would say more than 10%. And in these situations, we're doing it. But the clinicians, that's the big thing. Not Louis, but the others, they say, oh, we want a PET. But then they have false reassurance. And it is a cancer despite of the PET being negative. So there needs to be a learning curve there as well. And then one thing in Germany is we are very restrictive on ordering PET CTs. You have to have a biopsy result for cancer to do the staging, or for strain biopsy. So at least you try to get a biopsy, then the payers are allowing you to have a PET CT for staging.
Yeah, indeed. You made the point, why not another 3-month control? Because we already have a 1-year behavioral characterization here, yeah, of the nodule. Is the next case yours, Dorith?
Thank you. Okay, so this was this is a case of incidental lung nodule. So 48-year-old female. She had the CT of the abdomen and pelvis, which was obtained to rule out renal calculus. And you see this is the bottom of the lungs that you can see on this CT of the abdomen and pelvis from 2014. And at that year, this woman also had hysterectomy due to cervical carcinoma, and she was a 35-pack-year smoker. So I guess you can all see. Oh, sorry. So this is the nodule we're talking about, 5-millimeter nodule. And the first question is, what would you recommend for this incidental 5-millimeter incidental nodule in a smoker? Just taking into account that often as radiologists, we don't have this information. If a patient came to rule out a renal calculus, we would not always know. So 12 months low dose CT, nothing, or other. Okay, so people who said other, what did you think? So there is an option for 12 months, nothing, or other. 50%. So anyone would like to comment?
Yeah, I think Jens mentioned it before. There's a background of cancer there, right? So
The whole chest, okay.
We typically would recommend to do follow-up as in the post-cancer care, right? And it's a cancer case, a known cancer case, and we would report that finding and then put it into the MDT, not of the lung nodules, but of the cervical cancer conference. And then they decide on the, I mean, in conjunction with a pneumologist, of course, but they decide on the follow-up. And it's usually shorter than 12 months.
If it's early stage cervical cancer and she doesn't really need follow-up?
To do 12 months follow-up. Then you treat it as an incidental pulmonary nodule and do a 12-month follow-up.
Okay, so what happened with this patient was that actually it was overlooked. So the resident on call saw it. There was an attending physician who saw it in the morning. This was at night. And then the next time she had a CT scan was 10 years later.
10 years?
10 years later.
10 years.
Okay, so it was 5 millimeters. Now it's 10 by 7 millimeters. 10 years later with no increased uptake on PET. In Israel, they are more liberal with the PET CT. Okay, so what would you do? What would you do now? So 10 years went by. And only slight growth of the nodule.
Nothing.
Okay. So most of you opt for surgery. Okay. And the biopsy also comes close by, catching up. Okay, surgery or biopsy? Sorry. Okay, so I'm not telling you yet what the diagnosis was. And first, the questions for the panel. How should small incidental nodules be followed, if at all? And how suspicious is an incidental nodule which grew after 10 years and slightly? Okay, so who would like to start? And
When I
okay,
saw
Matt.
this, I
Yes.
thought I would say no follow-up needed, growth rate most consistent with benign pattern, but that was none of the options. So
Okay.
As I said, we would have done, as we said, we categorize it with a history, as it was not tumor because it was a very early stage cancer.
Okay.
And a very limited likelihood of that being a metastasis. I would follow it for 12 months. And of course, it's very suspicious for cancer if it grows, as there are very slow growing cancers out there, which have very slow growing volume doubling times above even 600. They're reported. And so, yeah, exactly. And so I would biopsy it first because we have learned that there are different entities which can grow over time and are benign. I don't list them up all of here, but sarcoidosis could be one, or TB, or others. We've seen a case of amyloid as well. So I think to even increase your positive predictive value of surgery, I would go for biopsy first and then surgery. Although knowing that its likelihood of being cancer above 95%.
Okay. Any other comments from the panel?
I would add the age of the patient makes a big difference and the comorbidity. So if it's somebody who's
So she
old-
was 48 10
Right,
years
she's
ago.
very young. Right.
So now she's 58.
She's still very young, right? So totally different from an 80-year-old that you see this nodule has been growing for the past 10 years and you figure, well, it's probably not going to kill her before she dies from some competing cause.
And
But
therefore,
since she's young, yeah.
what would you recommend?
Well, I agree with Jens. I would biopsy because there's that off chance that because of the slow growth, you do have the time and you might find something that is actionable, that is not malignancy, and that you would treat differently from a surgical resection. So.
Okay.
Yeah, I think because of her history, I would like to have a full CT scan to see if it's multiple or not. But nevertheless, and if they all grew, and it's very likely to be metastasis. In view of this one, it's a bit irregular. And so I think what I see now, it's more likely to be pulmonary cancer. And you need a biopsy.
Okay. Dr. Lee? Yeah.
I also agree. And some case of metastasis likely unknown primary cancer such as renal cell carcinoma is slightly very slowly growing. So
Okay.
it can be.
So you think it may be metastasis from
Yes, and
slowly growing?
Yes, and she also had the hysterectomy, so benign metastasizing.
Okay,
myeloma
so
can be
let's see
also-
what was the diagnosis. So we went for surgery and it was invasive adenocarcinoma 10 years later. You don't believe it, David?
Can I add? Can I add something to that?
Yes.
We have this tendency to think that nodules that are, when you have that much distance between the first and the, it's clearly not the same lesion as time goes by. And so you don't really know when it started growing, right? Because you had a 10-year difference.
Right.
So there's a bias there thinking that its doubling time has to do with the first and the last scan, but this might have changed. Maybe it was a pre-malignant lesion 10 years ago, and it became malignant 6 months ago, in the sense that it started growing very quickly. So I caution about, these long follow-ups where you don't really know the true doubling time, right? How recent this change might have happened. And tumors are very plastic and heterogeneous, and they acquire the capacity to grow fast when they've been growing slowly for some time. So I'd be very careful with assuming doubling times when you only have 2 endpoints and they're very far apart. Yeah.
Okay. Okay, so we go on to the next case.
That makes any sense. Yeah.
Thank you, Doris. So indeed, talking about slow-growing tumors and comorbidities, let me show you a couple of cases from the clinical practice. This is not lung cancer screening cases. So we make a summary history of this patient, case number 5, born in 1953, so 60 years old in 2010 when he had colon cancer. Heavy smoker, 40 cigarettes per day, gynecologist, a colleague of ours. In 2014, lung cancer, stage 1, resected, no problem. And continuous observation, CT follow-up for these 2 malignancies, and evidence of a small, relatively small, non-solid nodule in the right lower lobe, September 2022. Then we get to 2023, the first melanoma, 2024, the second melanoma, and we keep on scanning this lung. So the same nodule is now showing some solid component here. It's May 2023. November 2023, the lateral solid component slightly disappears and a new solid component appears medially. And May 2024, the morphology is again different. So this is one of those cases that you hardly understand whether there is inflammation within this nodule, what is going on within this non-solid nodule. What we might hypothesize is this is either an adenomatous hyperplasia or it is an adenocarcinoma. So question for the audience is now, how would you manage the evolution of the solid component in this case? Would you do a CT in 1 year, a PET CT, a biopsy, or a CT in 3 months, or even a surgery already? Pay attention, it's already a lobectomy in this lung. Dated 2014, and we are 10 years after with more or less stable. So most of the people are still going for surgery. 40% biopsy, sorry. 35%. 30% is suggesting PET CT, and we could be discussing about the accuracy in the outcome of this PET CT. 17% is for surgery. CT in 3 months is a minor option. CT in 1 year is 1 out of 7 voting people here. So here's what we did, another CT after 6 months, and this is what is happening in this lung. The big mass on the left lower lobe, this is a squamous cell carcinoma with an uptake of around 10. I go by heart. Yeah. Similar case, we keep them side to side because this is quite important for the non-solid opacity showing up. Another colleague, GP, 2004 mediastinal lymphoma treated with radiation therapy, 2020 transitional cell cancer of the left ureter, nephrectomy. We keep up with observation, CT after the transitional cell cancer of the left ureter. This is the so-called baseline first CT, June 2020, apical irregularities at the pleuroparenchymal interface. We see them bilaterally, so probably the definition that we had before to define the suspicion is not really applicable here. 1 year later, the left upper lobe shows probably some minor increase in density, but who knows? We keep up with the follow-up, and the shape of this finding is clearly changing, whereas on the other side, we're quite stable. So we have a full 3-year follow-up period for this patient here. And again, 1 year later, again, even more solid component growing up. This is a still native lung. We have all 5 lobes for this patient. What would be your management solution for this patient now? CT in 1 year, surgery, biopsy, or CT in 3 months? So we have a 4-year time span, more than 4-year time interval for controls, and we've been seeing this faint nodule of the left upper lobe growing and growing. So no one is opting for the conservative solution, CT in 1 year again, because clearly the solid component is growing up. Somebody's still hoping for some change in resolution in 3 months, but most of the people is suggesting surgery. And indeed, surgery also with the patient being very eager to have this thing taken off was the decision. So these are 2 very different cases because the management was quite different, but very similar for if you take a look at the evolution of the focal finding solid component within the subsolid nodule. So now a question for the panel would be more than one. First of all, when would you decide that an intervention is indicated for a growing solid component in a part solid nodule in a multi-cancer patients like the 2 that we have just shown here? Probably we can ask Dr. Lee first. He has also Asian experience with subsolid nodule, might give us an insight about that.
In South Korea, there are high incidence of subsolid lung cancer. So in South Korea, we decided to biopsy or direct surgery for slightly increase the size of solid component. Then, but some decision of patient is important, but we recommend the biopsy or direct surgery in the case in case of increase of solid portion and in annual follow-up.
Thank you. So, yeah.
I'm be reluctant to biopsy because you can have sampling error of such a heterogeneous lesion. So you might nail a part of the lesion that's not particularly invasive or malignant and then miss the part that is. So if there's a solid component that's growing, I think your surgery is your best option.
So you trust the growth? Yeah.
Yeah,
Yes.
I think it depends on the patient. And you said already, if there's a big emphysematous patient where I have a large complication rate, biopsying it, if it's too peripheral, like that lesion was, it's too peripheral for the endoscopic biopsy. So if that would have been a patient with massive emphysema, right, one would go for wedge resection first, and have a quick cut during surgery and see if it's cancer and do extended resection. That's how we would do it. I also agree with the others that it is highly likely a slow-growing adenocarcinoma. But if it's a patient where you can easily biopsy it, even if the case would show carcinoma in situ, right, we may know that we have a sampling error and resect it. The question is, in very few cases, you have a benign finding, then you would follow it. If it still grows, resect it, or you resect it immediately. But this is an individualized decision in the tumor board often, right? And one discusses this with a patient because that possibility exists, as you said.
So what you're saying is that indeed your information from the follow-up is already enough, and you're not focusing on and searching for tissue diagnosis before acting, right? Also, if you think about SBRT. Yeah. So is your opinion similar, Matt?
Yeah, so when the lesion contains a lot of air, because it's ground glass or part solid or subsolid, I don't know if I would believe if the result came back as macrophages and inflammation, I would think that it might be false negative.
Do you want to add something, Doris?
Just would anyone consider if it's an inoperable patient, let's say an older patient or with comorbidities, would you consider SBRT without tissue sampling? So, Vincent, yes.
Yes.
In very
Everybody
few
else?
cases, we do that, yes. And but they're also old then as well. They're sort of approaching 80, right? They're frail and have a lot of emphysema. Yeah.
So we haven't published this yet. We've sent it for publication, but we started a screening program in Madrid that's screened now 4,500 individuals that had NLST criteria plus COPD or emphysema as an additional risk factor. And 80 tumors were diagnosed with 7% combined incidence and prevalence, but 10 of those tumors were not confirmed histologically because of the severity of the COPD and the emphysema. And so they had SBRT and their prognosis was excellent. So.
Okay, I think we don't have, maybe we should finish now. Okay.
Good.
Okay. We have more cases, but we have 3 minutes until 6.
You want
One more.
one more.
Okay,
So
let's go.
the next case is about the scenario that Matt just mentioned. It's a 72 years old former smoker, 30-pack years, quit 17 years ago. Frequent travels to African region, but no major symptoms, but minor weight loss, 5 kilograms in 1 year, and dry cough. So this is the finding. Right upper lobe, big finding. How would you describe this right upper lobe finding? Is it cavitary lesion with thick wall? Is this a consolidation, just a scar, or a mass? Okay. So cavitary lesion with a thick wall is the most prominent candidate among the readers here. So cavitary lesion with thick and irregular walls might represent several pathological scenarios, but for sure this increases the risk of being a malignancy. So what would you recommend as a next step for this finding? Antibiotics and CT in 1 month, antibiotics and CT in 3 months, PET-CT, biopsy, surgery. As it was sub-Saharan Africa. So most of the people again here are suggesting biopsy. Take some tissue out of it. And indeed, we mentioned Matthew made the case scenarios accidentally, right? A few minutes ago.
Honestly, as a pulmonologist, I would have gotten a sputum for AFB. So if you get AFB in the sputum, then you know right away because you stain it. So
yeah,
could be tuberculosis. Yeah.
So we went first for PET, SUV 14 for the mass, and then mild uptake, you might call it in this case, for mediastinal lymph nodes. Biopsy was performed, transthoracic needle biopsy, with some undetermined atypical cells in the results. So what would the panel do at this point in time? Is this enough to proceed to surgery? EBUS. EBUS.
Check for TB.
Check for TB. So what happened is that the patients went for surgery. Oh, sorry. How would you manage this? So yeah, we out of time. We ran out of time. So it is, yeah, surgery, and it was indeed a TB granuloma. And congratulations, Luis, you got it very quickly. Yeah. So thank you to the panelists. Thank you, Dorit, for hosting me in your presentation today. And thank you for everybody for being here. Leaving the word to you, Dorit.
Okay. Thank you.